Hello and welcome to Chapter 15, Antipsychotic Drugs. So we're going to start out directly with schizophrenia. This is a severe, lifelong mental illness consisting of disturbed thinking, abnormal behavior, or an inability to understand what is real, and an impaired processing of emotions. It's broken down with several categories of symptoms. Positive symptoms are an addition of abnormal behaviors like hallucinations, delusions, and thoughts of persecutions. Negative symptoms are a reduction of normal behaviors such as reduced emotional responsiveness, social withdrawal, reduced movement, and lack of motivation within schizophrenia. Schizophrenia spectrum and other psychotic disorders refers to disorders defined by delusions, hallucinations, disorganized speech and thinking, disorganized behavior, abnormal motor behavior, and/or negative symptoms. Schizophrenia consists of the most severe of these disorders and has at least two of the features listed in this category. The symptoms expressed must be highly disruptive for a period of at least 6 months. The paranoid type are characterized by prominently positive symptoms, and the catatonic type are predominantly negative symptoms, including immobility. The disorganized type are characterized by disorganized behaviors and silly or immature emotional expression, and the undifferentiated type doesn't appropriately fit any of the other categories. It's kind of a catch all. The residual type are for patients who now exhibit less prominent symptoms of schizophrenia, but did so in the past. Longitudinal studies find that 50 to 70% of individuals diagnosed with schizophrenia exhibit chronic symptoms, and the remaining 30 to 50% of patients tend to exhibit residual features of schizophrenia. Patients with schizophrenia who exhibit minimal or no improvements after 2 trials with either typical or atypical antipsychotic drugs are known as treatment-resistant schizophrenia. For patients with catatonic schizophrenia who do not respond to antipsychotic medication, physicians may prescribe benzodiazepine, which tend to show some efficacy for reducing catatonia. Other disorders in which catatonia may occur include depression, alcohol withdrawal, as well as AIDS. AIDS can lead to inflammation in the brain, which in turn can cause a number of behavioral, cognitive, and physiological effects. Those with AIDS can inhibit psychotic symptoms, which may be treated with antipsychotic medications. For a functional outcome, a patient's inclusion into a community, behaving normally in social situation, and successfully employing psychosocial skills, all are goals. Here we see the cognitive impairment in schizophrenia. Individuals with schizophrenia tend to score lower on tests for cognitive performance compared to healthy individuals. In this figure, patients with schizophrenia were compared to healthy controls on the repeatable battery for the assessment of neuropsychological status, which measures memory, attention, and other aspects of cognitive functioning. Scores on the scale are plotted in increments of 10 on the x-axis, and the percentage of participants scoring within each range is plotted on the y-axis. The average score for healthy participants was 100, and the average score for individuals with schizophrenia was 70, a score that only 2% of the healthy participants had. The sensory gating deficit is characterized by a diminished capacity to filter out unimportant stimuli in their environment. Attendance to these unimportant stimuli may lead to misperceptions of their environment, possibly facilitating delusional behavior. Cognitive dysmetria consists of abnormalities in processing, coordinating, and responding to information. As a result of cognitive dysmetria, one may perceive hallucinations, form delusions, exhibit odd or disorganized speech, incorrectly respond to emotional stimuli, and have impaired attention and exhibit other characteristics found in schizophrenia. Schizophrenia is relatively prominent among the psychiatric disorders, affecting 1% of the world's population. This equates to about 3 million individuals in the US alone. The prevalence of schizophrenia occurs equally in males and females, although males may develop this disorder 2 to 4 years earlier than females and exhibit more severe symptoms. A modestly increased prevalence of schizophrenia occurs in the northern geographic regions and for individuals born during the winter months, the latter possibly related to winter diseases like the flu. No more than 73% of individuals able to find any employment, and only 14.5% of individuals find competitive employment. So there is a significant societal impact. The depression rates among individuals with schizophrenia are high, with as many as 10% committing suicide every year. Researchers find 16 to 18 years shorter lifespan among those with schizophrenia compared to the general population. In the general population, we find a 1% rate of prevalence for schizophrenia. This risk factor increases slightly to about 2 to 4% when there is a cousin, uncle, or aunt, a nephew, or a niece that has schizophrenia. Having one parent with schizophrenia increases the risk to 13%, and having both parents with schizophrenia increases the risk to about 50%. Having an identical twin with schizophrenia also provides a 50% chance of also developing schizophrenia. The remaining risks for developing schizophrenia come from the environment, which may consist of a response to stress, life events, or other factors. The prodromal phase of schizophrenia is characterized by schizophrenia-like symptoms that occur less frequently and with less severity than the symptoms found in schizophrenia. These include deficits in working memory, attention, sensory gating, and sociability. Attention impairments appear most predictive for the prodromal phase. In addition to these behavioral and cognitive features, those identified with the prodromal phase characteristics also exhibit reduced volume of cortical gray matter. Associations occur between the abnormal DISC1 gene and the occurrence of schizophrenia in Scottish and Finnish individuals. The DISC1 gene encodes for the DISC1 protein, which plays an important role in the cascade of signaling events that take place within neurons, as well as the development of neurons. DISC1 genes may affect cell migration, which can lead to architectural abnormalities in the cellular networks. Castellani, Melky, Gee, O'Reilly, and Singh examined monozygotic twins among whom only one twin had schizophrenia. They found many instances in the expression of genes of the twin with schizophrenia. These differences in expression were found for DISC1 as well as a host of other genes potentially implicated in schizophrenia. The most consistent observations suggest reduced volume sizes of structures in the left hemisphere and the temporal lobe, if we're looking at the structural differences. Studies also find reduced volume of the frontal lobe, including the prefrontal cortex, and the thalamus in the left hemisphere, and reduced connectivity from the thalamus to the cerebellum. The cognitive dysmetria theory refers to dysfunctions in connectivity between the thalamus and the cerebellum, and the thalamus and the cerebral cortex as contributing to abnormal sensory processing, timing functions, and the error processing, which may lead to many of the symptoms and cognitive disturbances. Imaging and postmortem studies tend to reveal a modest volume of reduction of the hippocampus in both hemispheres. Functional imaging studies also reveal abnormal levels of the activity in the hippocampus during auditory hallucinations, memory tasks, and even rest. The neurodevelopmental hypothesis states that the abnormal nervous system development leads to irregular neuronal signaling in the brain, resulting in the characteristics of schizophrenia. Genetics cause alterations in neuronal growth and development, which likely impacts synaptogenesis and myelination before and even after birth. Recent studies indicate that epigenetic factors may be critical in the expression of genes leading to such potential abnormalities in neuronal growth and development. These abnormalities might eventually cause the prodromal phase of schizophrenia during adolescence. The transition from a prodromal phase to the full onset of schizophrenia may later arise in reaction to environmental factors such as the involvement in prolonged stressful situations or even substances of abuse. The prophylactic treatment consists of a treatment to prevent the disorder from occurring. It's a first line approach for the prodromal schizophrenia consisting of cognitive behavioral therapy. This is where they'll learn to monitor their thoughts and behaviors, and from this therapy, statistically fewer patients develop formal psychotic symptoms than otherwise was predicted. Antipsychotic drugs reduce the prodromal psychotic symptoms and appear in some studies to prevent schizophrenia, although cognitive behavioral therapy appears to be at least as effective. Schizophrenia may develop from a combination of genetic and environmental factors. Genetic factors may alter the normal development, growth, and connectivity among neurons, and this may predispose an individual to develop prodromal features of schizophrenia. A response to environmental events may cause someone to shift from the prodromal phase to a full onset of schizophrenia. The first clinical diagnosis for schizophrenia was made only in 1871 by Ewald Hecker in Gorlitz, Germany. Hecker gave several psychotic young patients a diagnosis of hebephrenia, a term coined by his clinical director, Karl Kahlbaum. In 1893, Emil Kraepelin first named this disorder dementia praecox, noting the striking cognitive decline by relatively young individuals, particularly compared to dementias he had studied in the elderly. Eugen Bleuler coined the term schizophrenia because of what he saw as a splitting of psychic functions in this disorder and a consistent lack of increasing cognitive decline. Lacking a clear biological cause, coupled with the rise of the psychoanalysis in psychiatry, the psychiatric community in the early to mid 20th century were seeking causes of schizophrenia in one's upbringing. One of the most notorious of these now abandoned notions was the schizophrenogenic mother concept. During the early 20th century, psychiatric staff often employed confinement methods as purported treatments, which often included the use of an isolation cell or straitjacket. Staff members also restrained patients in ice baths for hours or even days at a time. Some psychiatrists induced fevers in their patients, which resulted in a temporary abatement of symptoms afterwards. By the 1930s, convulsive shock therapies using either insulin or electricity sometimes offered real gains in symptom remission, although only temporarily and with significant risk to the patient. The first of a series of techniques, collectively referred to as frontal lobotomies, began to be offered as a long-lasting treatment for schizophrenia, although they provided no symptom improvements and were made at great cost to the patient's health, assuming the patient even survived the procedure. There were several different ways developed to produce frontal lobotomies, but all of these methods involve penetrating the frontal lobe with an instrument, often simply a rod, and then moving the instrument around to destroy the brain tissue. The result was often described as the state of drowsiness and disorientation. There was also significant risk of death from these procedures from hemorrhaging in the brain. Walter Freeman is known for the transorbital leucotomy. The first procedure involved the use of ordinary ice picks, thus leading to so-called ice pick lobotomies. During this procedure, Freeman punched the instrument up into the frontal lobe through the inner corner of the eye socket. He then moved it around within the frontal lobe to destroy the brain tissue. In 1952, Henry Laborit administered a pre-anesthetic agent called chlorpromazine to his manic patients at St. Anne's Hospital in Paris in hopes that it might calm his patients. He found them calmer, and he also noticed an abatement of symptoms among those with psychosis as well. The efficacy of chlorpromazine, specifically for schizophrenia, was soon studied by John Delay, Pierre Denneker, Jean-Marie Hall, who published their findings on the effects of chlorpromazine in psychotic patients in the same year. This discovery revolutionized the treatment for mental illnesses and might very well have led to the Nobel Prize for its discoveries. The dopamine hypothesis states that positive symptoms arise from the excessive dopamine release in the limbic system. The hypothesis derives from the discovery that the antipsychotic drug acts as an antagonist for the D2 receptors, and that amphetamine, through increasing dopamine release, causes psychotic symptoms. The glutamate hypothesis shows that diminished levels of glutamate released throughout the cerebral cortex and limbic system may lead to the symptoms of schizophrenia. Support for this hypothesis comes from human drug overdose cases and experimental studies with the dissociative anesthetics phencyclidine, or PCP, and ketamine, otherwise known as Special K. An appealing feature of this hypothesis is that acute administration of ketamine and phencyclidine cause users to exhibit behaviors similar to negative symptoms and cognitive impairment, as well as positive symptoms in schizophrenia. Researchers and clinicians refer to the typical antipsychotic drugs as the first generation or classical antipsychotic drugs. The term neuroleptic is synonymous with a typical antipsychotic drug. The second generation or novel antipsychotic drugs are the atypical antipsychotic drugs. Third generation antipsychotic drugs describe newer agents that may differ pharmacologically from drugs in these other categories. We'll look at all of these. The first generation or classical antipsychotic drugs are the typical antipsychotics. It's a class of antipsychotic drugs that reduce the positive symptoms of schizophrenia. They have a weak efficacy for negative symptoms and cognitive impairment and produce extrapyramidal side effects at therapeutic doses. The pharmacological actions of antipsychotic drugs derive from the antagonism of the dopamine D2 receptors. Typical antipsychotic drugs may require as long as 6 to 8 weeks to produce full efficacy. So your typical antipsychotic drugs are effective on positive symptoms. They're generally ineffective on the negative and cognitive symptoms. The extrapyramidal side effects occur at therapeutically effective doses, and it's managed by an anticholinergic drug. Tardive dyskinesia is likely to develop after long-term use, and the mechanism of action is mainly through the blockade of D2 receptors. The atypical antipsychotics are effective on positive symptoms. They're modestly ineffective on the negative and cognitive symptoms. The extrapyramidal side effects are unlikely to occur at the therapeutically effective doses. Tardive dyskinesia is unlikely, and the mechanism of action is through the blockade of D2 receptors and serotonin 5-HT2A receptors. However, many other receptors are implicated in these effects. The extrapyramidal side effects, or EPS, consist of tremor, muscle rigidity, and involuntary movements. In the nigrostriatal dopamine pathway, which terminates in the basal ganglia, likely functions normally in schizophrenia. D2 receptor antagonism reduces the dopamine neurotransmission in this pathway, causing diminished control of movement. In many ways, extrapyramidal side effects resemble the features of Parkinson's disease, which may also derive from the disrupted dopamine neurotransmission in this pathway. For patients who are treated with a typical antipsychotic drug, physicians usually prescribe a muscarinic receptor antagonist such as benzotropine to reduce the extrapyramidal side effect severity. Muscarinic receptor antagonists further impair cognitive functioning in schizophrenia. Tardive dyskinesia is a motor disorder that affects muscles primarily around the mouth and other parts of the face. Characteristic features of tardive dyskinesia include facial tics and rhythmic involuntary movements of the jaw, such as chewing or teeth grinding, involuntary uses of the tongue, such as lip licking or excessive lip smacking and pursing. These adverse effects may not occur until after a patient stops taking the medication. In fact, tardive dyskinesia can persist for months and even years after stopping the typical antipsychotic treatment. The neuroleptic malignant syndrome shows flu-like symptoms such as sweating, fever, and other symptoms such as blood pressure changes and autonomic nervous system irregularities induced by antipsychotic drugs. These symptoms are severe and life-threatening. Any appearance tends to occur during the first few weeks of treatment. In nearly all cases, the extrapyramidal side effects also occurs with neuroleptic malignant syndrome. Hyperprolactemia occurs from abnormally high levels of prolactin over prolonged periods of time. The symptoms include reduced lactation, loss of libido, disruptions in menstrual cycles, erectile dysfunction, and hypogonadism. Dopamine D2 receptors regulate the release of prolactin from the anterior hypothalamus. Antiemetics are drugs that reduce nausea and vomiting. Given these properties, typical antipsychotic drugs might be given with general anesthetics to prevent vomiting during surgery, or be given to cancer patients on chemotherapy, which commonly produces nausea and vomiting. The chemoreceptor trigger zone is an area in the medulla unprotected by the blood-brain barrier that receives inputs from the substances in the blood. The chemoreceptor trigger zone sends signals involving, in part, dopamine neurotransmission mediated by the dopamine D2 receptors. The area postrema is the area in the medulla that produces vomiting. Many typical antipsychotic drugs, which again serve as a dopamine D2 receptor antagonist, may block signals from the chemoreceptor trigger zone to the area postrema, thereby preventing vomiting. Some typical antipsychotic drugs also act as an antagonist for the 5-HT3 receptors, a receptor action particularly linked to antiemetic effects. Clozapine was the first atypical antipsychotic drug. It was synthesized in 1959, only a few years after the discovery of chlorpromazine. Researchers disregarded clozapine as an antipsychotic drug at first because of the lack of experimental extrapyramidal side effects in animal models. So clozapine is not used clinically for schizophrenia until the 70s and 80s. The atypical antipsychotic drugs, or the second generation or novel antipsychotic drugs, are drugs that reduce positive and negative symptoms and carry a low risk of the extrapyramidal side effects at therapeutic doses. From clinical studies, we find some improvement in functional outcomes after atypical antipsychotic drug treatment. Atypical antipsychotic drugs may also reduce depression in schizophrenia. Clinical studies find that clozapine, olanzapine, and risperidone reduce suicide risk among individuals with schizophrenia. We also find improvements from some atypical antipsychotic drugs for treatment-resistant schizophrenia. Clozapine provides significant clinical improvements in 70% of treatment-resistant patients. Most atypical antipsychotic drugs will produce extrapyramidal side effects at a sufficiently high dose. Atypical antipsychotic drugs also carry a risk of neuroleptic malignant syndrome. These drugs may also produce hyperprolactemia. Atypical antipsychotic drugs have a lower risk, but not a complete absence of these adverse effects. Many atypical antipsychotic drugs produce significant increases in body weight, and we know that increases in body weight accompany a substantial risk of type 2 diabetes. The prolonged heartbeat, as revealed from the QT interval of an electrocardiogram, is the QT interval prolongation. The disorder characterized by reduced white blood cell counts in the immune system is a granulocytosis. The serotonin dopamine or the 5-HT2A D2 receptor hypothesis states that the atypical antipsychotic drug effects derive from the preferential antagonism of serotonin or 5-HT2A receptors compared to the dopamine D2 receptors. Pharmaceutical companies most often follow this hypothesis for developing new atypical antipsychotic drugs. The fast D2 off hypothesis states that atypical antipsychotic effects derive from a rapid dissociation of the antipsychotic drug from the D2 receptor. Atypical antipsychotic drugs do not block the D2 receptors for as long a time as typical antipsychotic drugs do. Here we see the pharmacological actions of atypical antipsychotic drugs generated from other receptor actions. With the alpha adrenoceptor or norepinephrine, the antipsychotic receptor action is an antagonism, and the effects may contribute to the atypical antipsychotic effects when combined with the D2 receptor antagonism. The D2 receptor, or dopamine, has an antipsychotic receptor action of an antagonism, and the effects are antipsychotic effects and extrapyramidal side effects. The H1 receptor, or histamine, is an antipsychotic receptor action with antagonism classification, and the effects include drowsiness, weight gain, and a risk of type 2 diabetes. Acetylcholine is our muscarinic receptor, classified as an antagonism. Its effects include dry eyes, dry mouth, and other anticholinergic effects. The 5-HT2A receptor is classified as an antagonism, and its effects include atypical antipsychotic effects when combined with the D2 receptor antagonism. Finally, our 5-HT2C receptor, classified as an antagonism, has effects of weight gain and the risk of type 2 diabetes. As we move to the third generation antipsychotic drugs, these are drugs that produce antipsychotic effects through a mechanism of action different from those that are typical and atypical antipsychotic drugs. The potential third generation antipsychotic drugs have deviated from the pharmacological actions found among typical and atypical antipsychotic drugs, so they have unique therapeutic effects. Aripiprazole functions as a weak partial agonist for the dopamine D2 receptors at therapeutic doses. It shares the antagonist effect of 5-HT2A receptors, making this drug somewhat similar to an atypical antipsychotic drug. Clinically, aripiprazole exhibits atypical antipsychotic effects because it's unlikely to produce extrapyramidal side effects at therapeutically effective doses. Aripiprazole appears slightly less effective than the atypical antipsychotic drug olanzapine for treating schizophrenia, but it might offer less risk of type 2 diabetes. Pharmaceutical companies provide all typical and atypical antipsychotic drugs in pill form, allowing for oral administration. In a hospital, patients, out of possible mistrust of healthcare staff, may refuse to take a medication or attempt to hide medication under their tongues. So during inpatient care, patients may receive intramuscular injections of antipsychotic drugs instead. The antipsychotic depot injection or long-acting antipsychotic injection provide a slow release of the antipsychotic drug over the course of weeks after a single injection. A depot administration circumvents concerns over patient compliance and provides for steady state of drug effects. The active metabolite of risperidone, called pipleridone or Invega, was recently developed as an atypical antipsychotic drug. The active metabolite of clozapine, which is N-desmethylclozapine or pimavanserin, has also shown promising antipsychotic effects in animal models. CYP2D6 and CYP2C19 enzymes metabolize approximately half of all types of the antipsychotic drugs. Polymorphisms for the enzymes cause some individuals to poor metabolizers and rapid metabolizers of antipsychotic drugs. This may account for how practitioners adjust dosing for patients to achieve the therapeutic effects or avoid adverse effects. For the polymorphisms of the CYP2D6 enzyme, Kirchheimer and colleagues found that dose reductions or increases among patients in clinical trials correlated with one's metabolizer status for this enzyme. A poor metabolizer or an ultra-rapid metabolizer may benefit from changing to an antipsychotic drug metabolized by another PY450 enzyme. Autism spectrum disorder, or autism in general, is a neurodevelopmental disorder consisting of social impairments, verbal and nonverbal language difficulties, irritability or emotional outbursts or tantrums, and repetitive behaviors. The general worldwide estimate of autism is about 1%. The CDC reported a 78% increase in autism diagnoses from 2002 to 2008. A five-fold increase in autism diagnoses occurred in the UK in the 1990s, but rates plateaued in the 2000s. A 4 times greater prevalence of autism is found in males than in females. Twin studies show that autism occurring in one monozygotic twin will likely occur in the other monozygotic twin. One study found that 92% of cases in which monozygotic twins received an autism diagnosis, the other twin either had autism or exhibited features related to it. Studies have mostly linked genetic abnormalities to multiple chromosomes, including 4 and 7. From affected chromosomes, numerous genetic changes could lead to the neurodevelopmental effects. A general consensus is found relating to abnormal connectivity in the prefrontal cortex, which may have implications in a host of cognitive, social, and emotional features in this disorder. The visual system activity may be out of sync with activity in the motor system, perhaps leading to an individual not visually perceiving or processing the consequences of motor responses. This might account for the difficulty those with autism have for imitating gestures. So how do we manage this? An applied behavioral analyst normally provides therapy for a child or adult with autism with the goal of correcting problem social, communicative, and adaptive behaviors. One of the primary psychoactive drug approaches involves prescribing antipsychotic drugs. Those currently approved by the US FDA for use in autism include aripiprazole and risperidone. Antipsychotics primarily manage certain features of autism, and both aripiprazole and risperidone reduce autism-related irritability and are specifically approved by the FDA for this purpose. In schizophrenia, disruption in neurotransmission occurs for glutamate and dopamine. In this image, we find underactive mesocortical dopamine neurons that originate in the ventral tegmental area and terminate in the prefrontal cortex and other parts of the cortex. Thus, dopamine levels in the prefrontal cortex may be too low. Diminished dopamine activity in the prefrontal cortex causes less activation of the glutamate neurons that innervate the ventral tegmental area and facilitate a positive feedback loop. Lower activity of glutamate neurons from the prefrontal cortex to the nucleus accumbens may result in less activation of GABA neurons that terminate in the ventral tegmental area. Diminished GABA neuron activity may disinhibit mesolimbic dopamine neurons, leading to the increased dopamine release in the nucleus accumbens and perhaps other parts of the limbic system. Thus, overall, this model demonstrates how dopamine levels in the prefrontal cortex may be low, while dopamine levels in the limbic system may be high. The positive symbols represent excitatory effects, and the negative symbols represent inhibitory effects. Microdialysis procedures reveal that atypical antipsychotic drugs, such as clozapine on the left, produce increased dopamine concentrations in the prefrontal cortex, although typical antipsychotic drugs, such as haloperidol, tend to have minimal effects on dopamine concentrations in the prefrontal cortex, shown on the right. The arrow indicates when the injection of clozapine or haloperidol was given. The y-axis allows the percentage of dopamine level change compared to baseline plotted at the 100% level. The x-axis shows the time before, with minus signs, and after drug injection. So we need to assess the effects of these drugs. Selective 5-HT2A receptors and D2 receptors on the prefrontal cortical dopamine concentrations. Legiosis, Ichikawa, and Metzler found that neither the 5-HT2A receptor antagonist M100907 nor haloperidol, a D2 receptor antagonist, significantly increased dopamine concentrations in the prefrontal cortex. After combining the two drugs, these researchers found significant increases in the dopamine concentrations in the prefrontal cortex. Based on these findings, the actions of atypical antipsychotic drugs on the 5-HT2A and D2 receptors may account for their effects on the cortical dopamine neurotransmission and possibly their ability to improve cognitive impairment and negative symptoms in schizophrenia.